Well, yeah, good morning to everybody. We welcome you very warmly for this session on thoracic surgery. And in the interest of time, we just start off. And the first talk is from Naples, will be presented by Fulvia De Puente, and it's about embolization versus surgical approach for pulmonary sequestrations. Please.
Mr. Chairman, dear colleagues. So the aim of our study was to evaluate and compare the results of the embolization and surgical approach of pulmonary sequestration in pediatric patients. This is a retrospective and multi-centric study that involved 3 pediatric surgery units and 4 pediatric cardiological units. Patients younger than 3 years old who received embolization and surgical treatment for pulmonary sequestration between January 2010 and December 2020 were included. Data regarding preoperative workup, demographics, intra- and postoperative details, and follow-up were collected. Regarding the technique, thoracoscopy was performed by 3 or 4 trocars of 3 or 5 cm. For the percutaneous embolization, the procedure was attempted by transfemoral approach, and a review was performed in all cases to identify the apparent artery that was embolized by a non-placer vascular devices. All procedures were performed under general anesthesia. As for data, demographic data, we found no difference in sex distribution and in intralobar, extralobar distribution. But we found a statistically significant difference between a fetal diagnosis and symptoms. That was made, the symptoms was major in the embolization group, and the thoracoscopy patients presented all a fetal diagnosis, and the embolization one, only 59% of them presented it. So we find also a statistically significant difference between height at the procedure, and particular that was significantly lower in the thoracoscopy group. No difference was found in the procedure time and ICU stay after procedure. But hospitalization was lower in thoracoscopy groups due to the 24 patients that were operated in their surgery. At the follow-up, at 1 year, all patients symptomatic become asymptomatic. And we found 1 patient in the thoracoscopy group who required a surgical revision due to an infected intralobar sequestration. In one of the embolization patients, the procedure was not concluded, and so it required a thoracoscopy. At the long-term follow-up, we can see that one of the embolization patients becomes symptomatic, and a recurrence was found. As you can see, only 6 patients, 18% of the embolization group, performed a CT scan and MRI. That was not performed in the surgical group, in which the follow-up was based on clinical examination and chest X-ray. In conclusion, we can say that both the techniques are effective and safe for pulmonary sequestration in children. We think that surgical approach can guarantee a complete resolution of the pathologies without leaving lesion tissue inside. And so, in our opinion, it must be the preferential choice, especially in case of intralobar sequestration or due to combination lesion. Embolization must be reserved in case of severe shunt and heart failure. In this case, we recommend a long-term follow-up supported by imaging. Thank you for your attention.
Thank you, Fulvia, for this very clear, structured study and the very clear results. And I fully agree with your conclusion. To my opinion, even pulmonary sequestration has to be reset completely, because there are also hybrid lesions when you can't tell whether it's a sequestration or CPAM. So are there any other comments or questions from the floor?
according to the radiologists, when they see an abnormal arterial supply, they call it pulmonary sequestration. But for pediatric surgeons, a pulmonary sequestration is a congenital parenchymal lesion with an aberrant arterial supply. So, in terms of your preparation for treatment, do you embolize the patients with congenital parenchymal lesions too, or just only the aberrant arterial supply patients?
Are you talking about intrapulmonary sequestration or extrapulmonary sequestration?
Both.
So in our study, both were performed. Also in intralobar and extralobar sequestration were embolized, and they embolized the aberrant vessel, really, only the aberrant vessel.
In my opinion, if a congenital parenchymal lesion exists, embolization cannot be sufficient to treat the patient because there is always a risk of malignancy in the long term if a congenital lesion is in the parenchyma.
Yeah, but that's more or less what she concluded about. But
yeah, I think we all agree here in this call that the surgery is better.
Yes.
Okay, so that's the reason. I have a question. Did you explore, did you do pathological analysis in all specimens?
Yes, the surgical group do it, and we found 3 mixed lesions, 3 combined lesions.
Muchas gracias.
Last question, please. Very nice work. Just one question. After this work, did you change anything in the circuit of the patients that reach the cardiologist?
I think that's the limitation of our study, that's a multi-centric study, and pediatrician who send the patients are not involved. I think this is the major problem. Pediatrician must be involved and must be known.
I think it's important to communicate to the pediatricians that this has a surgical solution for anything well. Thank you very much. Next communication also from the group in Naples is entitled Thoracoscopic Approach for Pulmonary Sequestration and European Multicentric Experience.
The aim of this study was to report an European and multi-institutional experience in thoracoscopy management of children with pulmonary sequestration over a 10-year period. This study was a retrospective and multi-center study involving the 3 European pediatric surgery units. The record of patients with pulmonary sequestration who underwent thoracoscopy between 2010 and 2020 were attentively reviewed. Data regarding demographics, surgery and follow-up were collected. So the patients were positioned and lateral decubitus with operative side up. First stroker was tumorally put on by an open access at the tips of the scapula to better see the lesion and decide where positioning the other trocar. At the end of the procedure, as you can see in the video, gently given me from Professor Bonnard, you can see the injection of anesthetic by a paravertebral catheter and the subpleural space. And the day surgery, no grave was left at the end of the procedure. So the study involved 34 patients. 94% of them received a prenatal diagnosis, and 94% presented no symptoms. All patients perform a CT scan or MRI before the procedure. 84% of our patients was younger than 1 year. And then 24 patients were performed in day surgery. So 47 sequestration, excision, and several lobectomy was performed. Surgical conversion was necessary in 5 cases due to intraoperative difficulties. Only 1 patient required the intervention for an infected intralobar sequestration. 2 patients of our series received a previous embolization. In these patients, no recurrence, no conversion was needed, and it was reported that there was only 1 systemic vessel. In 3 cases, a mixed lesion was found. We divide the patients into groups younger than 1 year old and more than 1 year. So we found a significantly low rate of symptomatic patients and less than 1 year. And also the procedure time was significantly lower. No difference in hospitalization and conversion rate. We also look at the use of sealing device that showed that there was a significantly lower procedure time in the sealing device group. We reported a median follow-up of 13 months, based on chest X-ray and clinical examination. All symptomatic patients become asymptomatic and no scar severe were reported. In conclusion, we say that thoracoscopy is a safe and effective procedure for children with pulmonary sequestration. It can guarantee a fast and safe recovery, avoiding severe scar severe. To reduce the risk of infection and make the procedure safer, we suggest to plan surgery in these patients before the first year of life and suggest that new technologies can simplify the surgery. Thank you.
Thank you very much for this nice multi-center study. We have a question from the floor. I would like to.
Thank you very much. You reported no adverse effects of the previous embolization. Do you have any positive effects of that? Was it easy to operate on? So the question is actually, why do we embolize? What happens to the lesion? So if we don't operate, why do we embolize? What happens to the lesions which are not embolized?
So we discussed it in the previous presentation. At the end, we conclude, in our opinion, we concluded that embolization must be used only in case of severe shunt, because to the high rate of recurrence naturally. So the patients can be performed in thoracoscopy due to the anesthesia problem. Yes, we can do embolization because it's less invasive, and the attempt to do the thoracoscopy, but there's no support to embolization systematically.
Well, can I ask you one more question? I'm also a huge fan of vessel sealing devices, such as LigaSure or ChestRite or whatever. I would be a little bit reluctant in using them for extrapulmonary sequestration, because we all know the vessel, if it's not really completely safe, can slip back into the abdomen and then bleed. So would you be concerned in using it, or may I ask Arno to comment on that? Do you always feel safe using the vessel sealing device for the dissection of the sequestration vessel?
Yeah, do you want to make a question first, or?
Yeah, I just saw your name on the list.
I never use only the LigaSure setting device. I'm using notes for the artery, because, like you said, in case of bleeding, the artery will retract in the abdomen. It can be an idea. So I always use notes. You can use split, but I don't like split. So notes is perfect to do that.
Are you doing 2 seals then, or?
I'm doing knots and I'm doing the seals on the side of the lesion.
Okay.
ask some details of some cases of interlobar sequestrations where decades surgery, which is not very common. So were there lobectomies or anatomic resections? Or
No, I'm sorry, but that was a multi-center study, so I don't have the precise information about that.
okay,
But generally was, again,
Mr. Bonato answer.
I can respond. So for the day case surgery, all patients with castrations are operated on the day case surgery basis in our center, even if it's intravenous castrations or extravenous castrations. And for intravenous castrations, depend actually on the CT scan findings. If you have some cysts around the lesion, it's probably a type 2 or a mixed lesion, so it can be a lobectomy. And otherwise, if the majority said that's only intravenous expressions and doing atypical resection. Yeah,
so
surgery.
that means you do not leave any chest tube on lobectomy?
No. For this, for lobectomy, yes. But if I'm doing wedge resection or atypical resection, I'm not doing a drain.
All right, thank you, Fulvia. Very good. We move on to the next paper, which is from Vincenza, and it's presented by Maria Conigi, and it's about the advantages of thoracostomy in the management of children with previous history of thoracostomy.
Good morning, Mr. Chairman, colleagues. We know that thoracoscopy has become the approach of choice in the management of many different thoracic malformations, but there is no reported consensus on the use of thoracoscopy after an open surgery. We present our experience with patients that came at our attention after being treated with an open approach in other hospitals. In particular, 3 of them affected by a type 3 esophageal atresia and the closure of the trapezoesophageal fistula. A patient presented after being treated for a type 4 esophageal atresia that had as postoperative complication the formation of a bronchoesophageal post-infective fistula. A patient presented with a residual esophageal duplication, and 4 of them had a partial resection of a CPAM. We perform all thoracoscopy without intra or postoperative complication and no conversion rate. These are some examples of what we found inside the thorax. And so a lot of adhesion between the lung and the pleura and the mediastinum, and we were able to perform the anastomosis once resolved the adhesion. Here is the patient affected by the bronchoesophageal fistula. And of course, also in this patient, we found a lot of adhesion, and in particular, a great tendency to diffuse tendency to bleeding that, in our opinion, was better controlled by a minimally invasive approach than open surgery. This is an example of a lobectomy after a partial CPAM resection, in which, as I said before, we found a diffuse tendency to bleed that was well controlled in minimally invasive surgery. Of course, these are difficult thoracoscopies, but with some tricks we can perform them quite well. For instance, difficult is the placement of the first trocar. That can be challenging because of the adhesion that we can find inside the thorax, and sometimes to create some space with a surgical swab before enter the trocar can be useful. And then, as we heard yesterday from Professor Rothenberg, use the optique to remove the adhesion is also a good maneuver. And then the thoracoscopy gives the advantages to move the optique between the trocars, and that was to see very well the whole hemithorax. And then, as I said, on our opinion, less tendency to bleed and better bleeding control. We searched literature and we found not so many experience about this topic. And in particular, they record the treatment of recurrent trapezoesophageal fistula. But in conclusion, on our experience, thoracoscopy is a safe and efficient approach after an open thoracic surgery, because we have a better view, a reduced risk of bleeding, and a better control, and as for every minimally invasive procedure, a faster patient recovery and a better functional and aesthetic result. Thank you.
Thank you, Maria, for this very clear
all patients that came to our attention are treated.
Any more comments?
Yeah, just one comment. The message of this talk could be also don't do sparing surgery in case of SIDA.
Yeah.
Yes, of course.
All right. Thank you, Marie.
Okay, so next presentation, also presented by Dr. Koenig, is entitled Double Lung Ventilation Thoracoscopic Surgery in Newborns and Small Children, Back to the Future.
Well, this work is made in collaboration with our anesthetist. We are from a general hospital, and our anesthetists work both with children and adults, and they usually do not perform one lung ventilation in small children. And we want to see how is the impact of the double lung ventilation in this patient. Of course, the anesthetist, as I said, had two choices of the traditional double lung ventilation on the one lung. The main indication for one lung ventilation is, of course, to facilitate the surgical exposure of the lung to the surgeon. But on the physiological point of view, it reduces the optimal ventilation flow matching, and in general, infants tolerate this procedure less well than older children and adults. One lung ventilation is, of course, a challenging procedure because of the anatomy of the lower airways and the size of the instrument, in particular considering the children smaller than 2 or 3 months. And the great limit could be the limited operator experience, because this procedure has important potential risk as the dislocation during surgery with problematic repositioning, or difficulty in ventilation or obstruction of the tube that can lead to severe hypoxemia. So, in the last 10 years, we've performed 92 thoracoscopy in children between 0 and 6 years old. In the great majority, they were under 1 year of age, and 47% under 6 months of age. We usually have an initial CO2 insufflation up to 868 millimeters of mercury with a flow rate that is 1 per minute to induce the lung collapse. Then we reduce the pressure up to 4 millimeters of mercury to stop or reduce as much as possible CO2 insufflation and maintaining it at the lowest level possible. We have 2 intraoperative anesthesiological complications: an endotracheal tube obstruction and difficult ventilation and hemodynamical instability in a CDH patient that need conversion to open surgery. No intra nor postoperative mortality, and all patients return to intensive care unit intubated. We analyze mechanical ventilation parameters, and considering the pressures, in particular mean PIP and mean PIP, we found low pressure. That means a reduced risk of barotrauma and ventilator-induced lung injuries. We, of course, analyze also the patient oxygenation status, and with a mean fraction of expired oxygen of 41%, that is a low level, we had a satisfactory saturation and also a good level of end-tidal CO2. So, in conclusion, of course, one lung ventilation is a nice product, but still presents important limits due to the lack of appropriate devices and limited operator experience because of low case numbers also in tertiary centers. Nonetheless, in our experience and opinion, an high-level thoracoscopic surgery in newborns and young children can be safely conducted also with a double lung ventilation. Thank you.
Thank you very much for this nice series. Do we have any questions or comments?
I personally learned from Steve Rottenberg that double lung or single lung ventilation is just not needed. So, do you think it's always justified to consider it?
To perform a double lung is justified when we have no other choice. Of course, also in our opinion, it could be useful to perform one lung ventilation. We have some technical limits in our reality, if you want. But we have found that we had a good result from patients. We don't have problem from the anesthesiological point of view, and it consents us to perform a correct surgery.
Can I ask to the audience who is performing double lung ventilation in this patient? Okay, right now.
usually, when you do single lung ventilation in a little patient with bronchial blocker, we found probably you saw in the slide, there was a lot of problem on dislocation and desufflation, etc. So comparing this data, finally, probably in the little patient under 1 year, 6 months, could be better for us. Only this. Thank you.
Thank you. So we move on to the next paper, and the next paper is surgery for anomalous pulmonary venous return and pulmonary arterial supply, the role of thoracoscopy. And it's presented by Safiel Topumshu, and the study is from Izmir, Turkey.
Chairman and dear colleagues. Partial autonomous pulmonary return is a problem of the pulmonary venous structures. If they are all anomalous, it's called total, and one or more, not all, then it's partial. And it could, the pulmonary veins could be drained to inferior spinal and carotid system vessels. The best example of these lesions are syndromes, which are generally a large vessel communicating to inferior vein cava, hypoplasia of right lung due to the pulmonary artery hypoplasia, sometimes anomalies of bronchial system and extraposition of the heart, such as these great big vessels in the shape of a Turkish sword, and it is my skull, it's into syndrome. And for aberrant pulmonary arterial supplies, it's another problem that we all very well know with pulmonary sequestrations. Well, for anomalous venous returning children, thoracoscopy utilization is very, very limited in the literature, and we had the chance to publish our case with a symmetrical syndrome to be treated via thoracoscopy. And we had managed to prevent the left to right shunt in that. So, anomalies, pulmonary venous returns, or aberrant pulmonary artery supplies may lead to right cardiac failure because of the increased preload. So, there are some treatment options, including the rerouting of the vessels by cardiovascular surgeons. We have talked a minute ago, the embolizations. The old school cardiovascular surgeons do the lobectomies and implantomies, and also a preference of vascular ligation. So we aim to present our experience and emphasize the role of thoracoscopy in a selected group of patients of these pathologies. So we have 5 consecutive patients during March 2016 and 2020, and the demographics, complaints, so radiological and echocardiographic findings, surgical methods, and complications, and the postoperative follow-up were earlier. You can see all the patients depicted in the table. The patients' ages were between 2 and 15. 2 had incidentally diagnosed, the other had respiratory distress, cough, or recurrent infections, and 2 of them had previous percutaneous embolization by a pediatric cardiologist. There were 3 of the patients had right cardiac dilatation already, and all 4 but 1 had a pulmonary hypoplasia. They all had dual supply, which means that they also have a normal pulmonary vein or pulmonary arteries. And the aberrant arteries were coeliac artery or intercostal artery or aorta. And the anomalous pulmonary veins were generally used vena cava inferior. But there is one also with percussocephalus greatness. And 3 of the patients had sequestration. As an example, just like the Smith syndrome identification, the tracheobronchus, the dextroposition, and the aberrant artery canal cocoon with capillary supply. This should be due to the hypoplasia of the pulmonary artery so that the lung can get oxygenized. And also, you can see the vessels communicating with the systems and the system, the venous and arterial supplies. So this is the signature ring coming here and diaphragmatic into the vena cava. And these vessels are all ligated and split. And so the preload was decreased. This is another example.
I hate to interrupt you. Your time is over. Please conclude.
Okay. So, for identification, when evaluating the pulmonary anomalous pulmonary venous return, there are questions to be asked if there is an aberrant artery is present or not. Is it a dual supply or dual drainage? And how large are the vessels? And in cases of pulmonary hypoplasia with dual supply, thoracoscopic approach for decortication and vessel ligation seems more beneficial than other percutaneous embolization. Thank you.
Unfortunately, in the interest of time, we have to move on to the next paper.
Okay, so next communication comes from Cento, Italy, presented by Fabio Valletta, entitled Thoracoscopic Treatment of Post-Traumatic Pulmonary Contraction.
Dear Chairman and dear colleagues, good morning. I have nothing to disclose. So actually to share with you this clinical case. She's a 16 years old girl that comes to our emergency department after a bike fall that caused a left blunt thoracic trauma with the bicycle handlebar. Despite a small pain on the side of the trauma, she was substantially asymptomatic. And the chest X-ray showed a small pneumothorax, and as you can see, there's a small amount of subcutaneous leak and a fourth rib displaced fracture, as you can see. Next morning, she was completely asymptomatic, and we were going to discharge her, but we were not so convinced. So there was some air leak, and there was a slightly raised left diaphragm, and so we decided just to rule out if there was some lung contagion or atteratese to do a CT scan. So we did the next day the CT scan that substantially confirmed the radiological picture, but showed also this situation because the lingula of the upper left lobe was trapped inside the site of fracture, as you can see here, and also in this picture. After the CT scan based preoperative planning, we decided to manage it by thoracoscopic approach in the right lateral decubitus with a posterior approach. And a good video. Very nice. I can show you. Sorry, it's not working. You have the video file also. Okay, thank you very much. So we face directly the tissue entrapped in the site of the fractures, and we reduce it by gently pushing outside the thorax, just to open the space between the two ribs, and we relaxed also the fracture. The lingula was not viable in our opinion, so we decided to do an atypical resection in the GIA, and we take off the specimen with an endocatch of 10 millimeters. At the end of the procedure, we also use, as you can see in a moment, some glue because the periosteal shelf was not present, and so we managed, as you can see, the situation. This is the final result. I move on. Okay, clinical outcome post-operative period was substantially eventful. We discharged her after 6 days, and till today we have no referred related complication. We checked also the literature, and we found 7 cases of lung entrapment in the site of fracture, and also 2 cases of diaphragm and 1 case that is not still published of liver involvement. And so to conclude, this is, we think, a very rare condition, but also in the literature, most of the time is completely asymptomatic. And so we recommend that if you want to avoid misdiagnosis, to do a CT scan in all high energy trauma that are in a small area as bicep-handlebar in the thorax. And we think that we are good operative planning, thoracoscopic approach to be safe and effective option. Thank you very much.
Thank you very much for this nice report. Are there any comments or questions from the audience?
Can I ask you a question? The indication for resection of the lingula, would you be cautious just to wait if it gets recovered?
It was a lesion that was stayed inside of the decompression, lasted at least 24 hours, and to our opinion, during we didn't trust that this
Did you examine it pathologically?
Yes, there was a lot of, it was a contusion, there was hemorrhage, bleeding, and so on.
All right, thank you.
Thank you very much.
So we move on to the next table. It's a comparative study of thoracoscopic versus thoracotomy approach in diaphragmatic penetration, and it's presented by our president, the incoming president of ESPES, Juan de Agustin.
Good morning, thank you very much. This is a comparative study of 2 different surgical techniques for diaphragmatic plication in patients with phrenic nerve paralysis. And all of them were symptomatic in this way with failure weaning from respiratory support, hypercarbia or hypoxia or respiratory distress. And the diagnostic tools that we used were mainly thoracic X-ray exploration. At the beginning of the series, diaphragmatic evoked responses and diaphragmatic ultrasonography in more recently. This is the ultrasound study. You can see in the left normal diaphragmatic movement, and in the right left diaphragmatic paralysis with no movement. The techniques we compare are thoracotomy and thoracoscopy using 2 ports and 1 epidural needle, all of them with a mattress suture, and it was published in 2013 in the Spanish Journal of Pediatric Surgery. This is the thoracoscopic technique that we are using, and the post-operative control is by X-ray exploration. In total, there were 103 patients in 14 years, by thoracotomy 71 patients and 32 by thoracoscopy. 92% were iatrogenic after cardiac surgery. The age of the patients were not significant among both groups, but there were more newborns in the thoracoscopic group. The size of the site of the lesion was similar in both groups. The etiology was mainly cardiac, after cardiac surgery, similar in both groups, and the surgical repair duration of the operation was similar. There was a difference, but not statistical difference, was the time on respiratory assistance. The thoracoscopic group was 23 days versus 78 days. The time, but was significant difference in between time of endotracheal intubation, 2.4 versus 6.3 days, and post-operative chest tube duration, 2.3 versus 4.6. The stay in the ICU and the hospital stay was the same in both groups because of the underlying pathology. The post-operative course and complications are shown in this table. Intraoperative complications were non-statistically significant, but we had only 2 pneumothorax that had to be inserted post-operative thoracic tube at the ICU in the thoracoscopic group, and in the thoracotomy 4 pneumothorax and 2 bleeding. Post-operative complications were only 1 in thoracoscopic group, 1 wound infection, and in the thoracotomy group, 5 patients, 2 infection, 3 lesions of the wound. What was significantly different was the intraoperative tube insertion was only in 59% of the patients in the thoracoscopic group and 82% in thoracotomy. Also there was a difference in between the time the tube was in place. Recurrence was less in thoracoscopic group, but not significant, 6.3% versus 18%, and mortality was the same. So in conclusion, thoracoscopic repair, we found that it was statistically significant difference in post-operative time of tube, endotracheal tube, and also in drainage. Also, not statistically significant difference. We found quite low ventilatory support and especially in complications with no musculoskeletal morbidity in the thoracoscopic group and less number of recurrences. Thank you for your attention.
Gracias, Juan. So I guess the standard of care now is thoracoscopy.
Yeah, it was something that was easy to introduce because when you show that thoracoscopy is surgically easier, so it was absolutely accepted by the cardiac surgical team. So we received all their complications. Sometimes they are it's complicated to get into the thorax because if they drain the thoracic cavity with tubes, we find a lesion. But it's the standard of care now in mass.
Just one short question, Stefan.
Thank you very much for that nice presentation. So why do you need a chest tube at all?
Well, that's a good question because always we leave our tube when we are not comfortable with the operation. For instance, we operate many newborn preemies, babies. The lung is very soft. We think that we can have some leaking or respiratory problems, so we leave. Also, many of them, they have pleural effusion when they are coming to the operation, so we leave a tube when we found pleural effusion or bleeding. That can be some kind of blood into the pleural cavity. So in those cases, we leave a tube. We try not to leave a tube always, but we leave when we find those findings.
Thank you very much, Juan Carlos.
Thank you very much.
So we move on to the last communication of the session, which is entitled Thoracoscopic Management of Esophageal Atresia, Single Center Experience and Early Report from Cara.
Morning, dear chairpersons, We know thoracoscopic advantages for repair of esophageal atresia, but there are no standard indications, procedure, and perioperative management for thoracoscopic repair of esophageal atresia. Since the first case of thoracoscopic repair of esophageal atresia was performed in September 2020 in our center, this procedure has been considered as the surgery of choice. During the last 2 years, we performed an average of 16 surgeries for esophageal atresia annually each year. And the aim of the study is sharing our experiences. This is the algorithm which we use for choosing patients, managing patients with esophageal atresia. If the patient is hemodynamically stable, we go through a thoracoscopic approach. If the patient is not hemodynamically stable or very low birth baby, we thoracoscopically ligate the fistula and with or without a gastrostomach procedure. Then with a second thoracoscopic application, we try to perform a primary anastomosis. Here is the details of our operative technique, and we always perform a flexible bronchoscopy before the surgery, and we try to don't ligate the azygos, but it is not a certain rule for us. And we ligate the fistula with etymons or clips, and G-tube is always passed under direct vision to the anastomosis into the stomach, and we do the anastomosis with 5O micro interrupted sutures, and we always put a chest tube. And this is a little video. We are performing flexible bronchoscopy for all patients through, if the patient is tolerates from a laryngeal mask or from the ET tube. This is how we put the patient on the table and the places we put the trocars. And a little video, we start with bronchoscopy, and the thoracoscopic vision is perfect. You see, we start with finding the lower coach, and we use sliding knot for all patients at the first stage, and we use NG tube and chest drain. I would like to show you the sometimes finding the distal coach may be difficult. The insufflation is an important landmark, and also venous fibers are landmarks. And it was a complex case with an aberrant right subclavian artery and right arcus aortic arch. In this patient, we perform only at the first stage ligation of the fistula. In our results, we managed patients, 2 of them with type A, 1 case was type B, and 24 cases but with type C. Our patients had 33% of the patients had a prenatal diagnosis, and our mean birth weight was under 2 kilograms, 1,900 grams, and 55% of the patients were under 2 kilograms. And we can perform at the primary anastomosis in the first stage with thoracoscopy in 20 patients. And 3 patients died after surgery. These patients were who managed only fistula ligation. And I would like to show our bronchoscopic findings. 15 patients had the fistula at the level of carina, and 7 patients had suprarenal, okay, and 2 patients suprarenal. And our anastomotic leakage was 30%, and anastomotic rate was 25%. Recurrent was happened at 1 patient. And there are, in the literature, there are many perfect studies. And my last slide includes our lowest weight patient. She was 26 weeks old, gestation age baby. She was 585 grams, and we performed first stage thoracoscopic ligation. After the second primary anastomosis, she is going very well. Thank you so much.
Thank you very much. We are behind schedule. One short question, please.
I think this is a very interesting paper because you were exploring the bronchoscopic findings, and my impression is that we are having more patients with carinal fistulas than in the past, and my impression also is that we are having more short proximal pouches. I don't know if that is because we have a better view than when we use the open technique, but I think could be a more reliable findings will be using the bronchoscopy and thoracoscopy view.
Thank you so much. Exactly, you are right.
So we have to end the session. Thank you very much to all presenters.